Hello, and welcome to our webinar, Healthcare 2020, Modernizing Healthcare with Unified Patient Records. Fabulous topic. I'm Dr. David Nays, Chief Medical Officer here at Innovaccer, and I'll be the moderator for today's session. And I'm really excited to welcome our two panelists. Many of you may recognize them. They've both been landmarks in creating value-based care in our industry. So first of all, I'd like to welcome Jonathan Bush, Executive Chairman at Firefly, and many of you know him from his legacy as co-founder for Health. Jonathan, welcome to the webinar.
Thanks, David. Looking forward to this with bated breath.
Awesome, awesome. And then also Glenn Steele. Glenn is famous for his time at Geisinger and more recently as Vice Chair for the Healthcare Transformation Alliance, going upstream to really start focusing on the employer and the employer as a purchaser. Glenn, welcome to this webinar.
Thanks, David. Great to be with you. Great to be with you, Jonathan.
Yeah, and you guys know each other pretty well, so this will be a fun dialogue. So let's get started. So everybody talks about data these days, right? The importance of data. I'm here in Silicon Valley. Everybody's talking about data when you walk down the street. What's going on in terms of a data problem in healthcare? Jonathan, why don't we start with you?
Well, I think it's the same problem that healthcare often has, which is the ability to produce PowerPoint slides dramatically exceeds the ability to produce the truth about which the slides are written. That's true in anything, obviously, but in medicine, due to wonderful things like the Hippocratic Oath and the desire for a safety net, and horrible things like all the regulation that comes up around that and a lot of the monopoly power that's there, it just makes things go slowly. So in medicine, we talk about data and the things we could do with data, and everybody vies to get lots of data. But the truth of the matter is, it's actually just not that integrated. The practical, tactical work of building on-ramps and getting things to flow through them, and getting a kind of a highway system that navigates duplicates and mismatches and gaps is still in its infancy, even as we can't stop saying AI and ML and do re mi.
Yeah, that makes a lot of sense. And Glenn, you've had a long legacy of thinking about whether the EMR will really solve all the problems in this world. And looks like very few hospitals are in a single EMR. So where do you think the major challenges we have with data in solving the problems we have in healthcare today?
Well, first of all, most of the EMRs were not designed specifically to improve how healthcare is delivered. That's number one. Number two, the data that has to be aggregated in order to provide optimal care comes from a whole different set of silos. So you've got to have a function, and obviously we're here on behalf of innovation. You've got to have a function to aggregate data. You've got to have a function to present it in an extraordinary, easy to use interface with either the patient or the provider, and it's got to enable fundamental change in how care is received and how care is delivered.
No, and you've made an excellent point. It's not just about the EMR. There are all these sources of data, right? Claims data, patient data, lab data, electronic health record data, Fitbit data. So how do we think about all these sources of data and the journey that a patient has to go through? So, I mean, we've all been patients. We've all had family members, who have challenged. Jonathan, you and I were just talking about this earlier today. What's a patient to do? How do they really think about the healthcare system and navigating it? Like most of them, I think, have a primary care physician, might be on an EMR. Glenn, what do you think the importance is here of the primary care in terms of their role in really helping the patient through the navigation of the healthcare system?
Well, look, this is a personal point of view, obviously, but it's one that I had when we were trying to redesign what we were doing when I was at Geisinger. I believe that it's a combination of aggregated data presented in a useful way and a long-term personal relationship with a caregiver. In some cases, that's going to be a specialist, but for most of us, who aren't facing our mortality, it's ideally going to be a primary care physician or a nurse practitioner or what have you. And it's that combination of enabling technology and data presentation plus a long-term personal relationship that really, I think, optimizes how data is used to determine, what care should be looked at, and how care should be delivered.
No, it's an excellent point. And, I think in today's world, as people are starting to leverage these EMRs through value-based care and other sources of data, they've started to think about redesigning their practice. So they may have care managers in their office, they may have social workers in their office, and they all may be leveraging different access for data sources around what they do. Jonathan, I know you thought about this a lot at Athena Health, like how do you best support the primary care practice? Where do you see this issue of systems and data in terms of really transforming practice to be successful today?
Yeah, I mean, I think a big part of the reason I got booted from Athena was my efforts to try to dig back out of the hole I dug, which was the right hole to dig at first. So in order to get people onto AthenaNet, we said, look, we'll get you paid 6% more and 30% faster, because we'll sort of automate and inject intelligence into the scut work of your claims-based world. Our medical record basically said we guarantee you'll get meaningful use payments, which again was a very the atomic unit of all of that was the claim. It wasn't the patient. Epic's rise to success came with, the promise of creating essentially vertical monopoly. We're gonna make everybody in town be sort of in the biosphere or not, and we're gonna refer to ourselves and protect, make sure all the claims hit one place. None of these, all of these were the necessary logical next steps of medicine in a business context, and all of them sort of further and further tracked away from the atomic unit of disease, right? If you think about the atomic unit of disease, it certainly used to be infectious disease or traumatic injury, which you could imagine fixing with a claim, right? Gets by a bus, comes in, fix a lot of stuff, send out a big claim, all better. Now 80% of disease is behaviorally determined, involves lots and lots of tweakings across lots and lots of modalities, and the business model stuck inside of this claim. And so as institutions switch to value-based payment, as new institutions come up seeking value-based payment, either through the payer or around the payer, you see more and more employer direct, the atomic unit that you need is now the patient. A little bit like Glenn's point about, the original atomic unit was this long-term relationship. I don't want to screw Dr. Jones, and Dr. Jones doesn't want to screw patient Smith. And so they keep in touch. We're trying to replicate that now at scale with a tech stack and an ecosystem around that tech stack that is still oriented around the claim. And as you add these new nodes that you've put in your slide here, you have a huge information distribution problem that grows, logarithmically, disproportionately as you add more nodes that you want to keep in the loop that aren't on the same system.
It's an excellent point. And, again, I'll point out many of us have been family members, and generally, people might want to involve a family member in terms of their care. They're disconnected from the system. Now they may have a communication device, an Apple, handheld or a watch. And then you brought up an important point. The claim isn't going to not only capture social information, community or family information, but it's not going to capture these tools that are being given by employers. Glenn, I know you've been really invested in trying to think about what are the toolkit that can really help the employer think about, the healthcare that they're purchasing, because that's really where the claim, is part of the process of their outsource, management for that. So where do you see this from the employer perspective of how all this information will get pulled together?
Well, HTA is my present focus, and that's a cooperative of 53 very large self-insured companies. Got about 7 million sponsored lives, account for $25 billion of healthcare and pharma purchase a year. And what we're trying to do is to enable our employees who have an average span of employment with our companies of 12 years to get to making the right decisions about who is in charge of their health maintenance or their health care once they have a diagnosis, so that the employees are healthier over a longer period of time, optimize their health status and their productivity, basically. And all of this depends upon two things. It depends upon presentation of data that is not in silos, and quite frankly, it depends upon a relationship that we can help establish between the employee and an appropriate quarterback for how the data is presented and how the data is interpreted. And Innovaccer, basically, we haven't talked about Innovaccer yet. That's the reason I think we're on this hour-long webinar. I mean, Innovaccer basically is an agnostic enabler of putting the data together and presenting it in a meaningful way to a patient or one of our HTA employees. And it also has the capability of putting the data together with whomever that quarterback provider is.
No, that's an excellent point. And we all feel passionate that whatever primary care is or who a primary care provider is, that would be a potential quarterback. It makes sense. But it really is all about the patient. So not only are there these new data sources I've listed here or there, but the traditional ones, right? Patients go to a hospital. They may go to two different hospitals, one for an X-ray, one for an orthopedic visit. They obviously get labs, they get done, and go to a pharmacy, pick up prescription. And then Jonathan brought up the point that the one point of view that people at least get, which is delayed and still partial, is the claim. So there's all these data sources and nothing centered around the patient, right? Not a complete holistic view. And Jonathan, I know you've got some viewpoints of what having a patient-centered record available in the cloud that's available in a private and secure way to people. What would that provide us as we move into this future of value-based care?
I think that, and you asked the right question, because without a business model creating a gravitational pull, you can have all the standards and all the federal, meaningful use booster programs in the world and all the PowerPoint, God knows, in the world saying something ought to happen, and the dominoes still just won't line up and knock each other. So in the case of sort of medicine today, you've got two things. You've got a massive share grab. You've got major vertical integration, and you've still got excess capacity. So being able to do CRM, customer relationship management, in a way that is compelling, that is at least half as good, hopefully more, as we're used to outside of healthcare, becomes a mandate for any provider brand. How do I keep not ready on the other side of the ambulance to do amazing work, which is sort of now accepted as game stakes, but able to keep track of life events, social determinants. You have the little Apple Watch, able to keep track of what network you're in and how to get things done. Those are, efficiently, cheaply in the context of the rising number of folks that have deductibles. That's the first role is CRM. Obviously, the second role is, running the behavioral determinants versus emergency room consequences bet. If I do a tech savvy, sophisticated enough job at staying in touch with people, then their myriad regular American lifestyle diseases won't accelerate to the point where they start bonking off the emergency room and I get a bill, or they start bonking back into the hospital after I discharge them and I don't get to bill for it, or I can only bill half as much and I lose money. And then of course the third one, which is growing, is if you don't figure out how to actively manage people so they don't hit the system, some commercial player will come in ahead of you in the supply chain and essentially disrupt your business. So, we've watched the IPO of Livongo, and I think mostly people are happy about it. But what it does mean is that if it works, that's a lot of care that lots of local providers were thinking that they would give, that has now been essentially cut off at the pass. So those three things, that CRM, that ability to win at risk, and the ability to keep the business, keep full risk, meaning full dollar, not the risk of what remains after it's been picked apart by direct to employer players. Those are the three things that have changed in the business model in the business model of being a provider in the last 12 months, and are going to continue to change pretty aggressively in the 4 years to come, if I understand the polls correctly.
Yeah, no, it's an excellent point. And, it all is about a business model. And that means you got to be able to really meet a need if you're going to get this patient-centered view of all the data and leverage it to what Secretary Czar said, I think about a year ago, is, we need a way to deliver care better, pay for care better, but most importantly, a new data model to manage all this data. So let's do a quick check-in of our audience. We have a poll. I'm going to ask members of the poll to just sort of log in here. What are the major sources that your organization is currently using for data sources? Is it multiple EMRs that you've got trying to leverage and integrate across your system? Are you able to integrate claims data in that? Do you have a central EHR for everything you have that's managing everything? Or do you have a unified data platform that really has a common data model and is able to build pre-built connectors and bring data in quickly from everywhere and supply them to all the members of the ecosystem? So quick check-in. Poll is up, and we'll give you a minute or so to answer. And in the meantime, Glenn, I'd like you to get your point of view about that business model that Jonathan was just talking about. He made three great points about kind of what a practice needs to think about today.
Yeah. Well, first of all, we're in transition. I mean, we still have a huge amount of market that is based on payment for units of work, but there's no question that for the public payer, there's a continuing move to value-based, and that just is not, that's not accomplishable as a business model for most providers, unless they've got the kind of data that that we think we can put together and present in a usable form. And a huge amount of the success in the business model is doing away with unnecessary or hurtful utilization, quite frankly. Now, the rest of the business model obviously is based on having a competitive price per unit because of the continued fee for service. But even having a competitive price per unit means that the providers have to have enough data in order to understand what the real costs are for what they're delivering. So that's the business model from the provider side. The business model from the patient side, quite frankly, is if you get a lot of crap done and it's not helpful, it's quite often hurtful. So, the last thing you want to do as a patient or a sponsored life or an employee is to go to someone where you're going to get a lot of crap done, whether it's diagnostic or whether it's therapeutic. And then the business model for the employer, the 53 companies that are part of HTA, is pretty straightforward. Those companies do not want to be the last remaining engine of margin redistribution as the public payer squeezes down. And even though the self-insured revenue that's coming into most providers is a small part of the revenue mix, it's still a huge part of the net income mix. And trust me, the purchasers that I'm working with are aware of that, and that's not going to stand.
No, that makes a lot of sense. Well, let's check in with our audience and see the poll results. It looks like they popped up there for a second. Can we bring those up? Wow, so equally distributed amongst what people are dealing with. What do you guys think about this? Let's start with Jonathan.
What is the major source the organization averages? Is that averages, or am I reading it wrong? Oh, sorry, leverages.
Yeah, are you using?
I mean, I guess this is the point, right? I mean, the original fantasy, and Glenn probably got the PowerPoint presentation from the Epic people, and I would give anything to have seen one. But there was originally a McKinsey study that was for wherever Joe Swedish was working, somewhere in Seattle, that became the sort of industry standard that to protect your referrals, you gotta build a single closed biosphere, information biosphere. And don't worry, you'll have coordination of care because all the data you need will be on our 29 component megasystem. And so all the major systems did that. And then there was a study, and Glenn, I don't know if you saw anything more recent, but that no major Epic customer had gotten to more than 58% of the total data points coming from an Epic source. In other words, 42% are always still, even after you buy a single integrated system, 42% of what you need about know about patients is still coming from somewhere else, from the urgent care, from the skiing accident at Vail. And so what you see here is a wide range of sources that you need to pull stuff together from. And the point is, it almost doesn't matter which one the source, which one is the most in the survey. The point is, you always will have a plethora. And as society moves along and we get better with the Internet of Things and our Apple Watches get into our brains, you'll have more and more and more sources of data. And so the big existential challenge is, can we find a costless enough or cheap enough way to pull a myriad of ever-changing sources into a unified model, such that we can use the data without the cost of accessing it exceeding its benefit?
No, that makes a lot of sense. So great results. It's really, we're dealing with a very scattered environment. So let's move on. I think what people now are talking about is a need for a unified solution. And that's what we've been getting at here. Like, healthcare's information scattered in lots of silos, no comprehensive meaning, and we really need a way to bring that all together. So at Innovaccer, this is the way we look at it. If we can bring in everything in pre-built connectors from all of these different organizations, including community health organizations, and really unify it in a common data model in the cloud and make it accessible, what's the potential here? So it really starts with a patient-centered view at the practice. But there's tremendous value if you can leverage all this information from a common data model. Glenn, you've seen this, where decision support can be given in an EHR from a broader view and really help machine learning and augmented intelligence, or automate, is a way to, I think about it, augment the intelligence of the EHR and the doctor. What have you seen in terms of what we can provide with such a cloud-based approach?
Well, back in the day, when I was at Geisinger, we thought we deserved the Nobel Prize because we were able to combine the payer database with the healthcare delivery database. And now we've gone so much further than that in terms of expecting social determinants, non-medical aspects to come into play for decision-making on the part of the patient, and obviously for appropriate provision of care. So, I think, we already showed that with a population of Medicare Advantage patients, we were, and with the appropriate aggregation of data, and with the presentation of the data in a usable form by patient and provider, and that's a big caveat there, that we could save 25 to 30% of costs for prevalent chronic disease management, and also probably 20 to 25% of costs for prevalent acute care management. So that was back in the early days, and I think that that's just a baseline. The complexity of data aggregation is much greater now with an expectation to manage social determinants. But the rewards of that, particularly with the Medicaid population, are huge.
And I think if you have this patient-centered view of all the information, which Jonathan was pointing out before, you can not only leverage it in the cloud and connect all the members, we call it a connected care framework, all the members of the ecosystem, but you can start automating the work of the care coordinator, bringing the most important patients to the top of the fold and link them in with the rest of the team. And you can start thinking about transforming your practice, like Jonathan talked about. He tried to do it at Athena Health, and then personalize the engagement of the patient in that process, and start building your own applications and learning about where you really can add value with patient care. And for when the patient needs to go to a health system, to a hospital or something, you can start thinking about intelligent command centers that really look at the way that you're performing within your overall creation of value and financial management. So, Jonathan, does this fit a view of where you think things could have gone with the work you tried to do at Athena Health?
Yeah, as a young child, I learned it's really hard to put toothpaste back into a tube. and I was unable to retain, the history. What is it? History doesn't repeat itself, but it sure does rhyme. I didn't realize as I was trying to go back through 103 million patient records, 19 petabytes of data that were organized around, 119,000 doctors and their claims, to get it back up so that it could be patient-centric would be quite so painful. And what I love about Innovaccer and what made me devote, what little time I have to this is that when you start from scratch with the right architecture, everything is so much easier. And these guys, A, are brilliant, but B, took a risk and said, we're going to be able to reuse these very expensive things. We're going to build a thoughtful enough unified architecture, data model that people will use us as default to us as the unified patient record. Athena did that too. It was a crazy idea at the time. We're going to remember every time a claim gets denied, ask the 5 whys, figure out the root cause, and then anytime anybody wants to push that one claim through the tunnel again, we'll know the 1,000 reasons why it might not get paid. These guys are doing the same thing, but this time around the notion of essentially ETL, the suctioning of all the data from all the places and putting it into a framework that makes it consistent, reliable information. Lots of people have done ETL. We all do it. Everybody does lots of extraction and transformation of data and loading it into another system or another database all day long. And what these guys have done is a bit of a Hail Mary pass to try to get one single model so that all of their extraction and transformation work can be reusable by everyone. It's a national utility, a lot like the early electronic claims utility after the Bush 1 administration, where the cost of going to all these bloody payers, and certainly the cost of the payers going to all these hundreds of thousands of providers, was too high electronically. So people said, like, I'll do all the ETL work for you, just come to me. And those utilities helped us dramatically back in the days when we were still doing paper claims. This hopefully will be the same idea.
Yeah, I think I was always struck when working with IT folks in big systems. It was all about just moving data around from one place to the other. That's the way their lives were spent. Let's just get it all into one place where it's useful. I think it's a great point.
It was horrible. We had a huge R&D budget at Athena, partly because I was trying to re-platform, but there were 400 people doing nothing but ETL, customer by customer by customer. And this was a pretty advanced cloud-based company. And very little of that clinical ETL, not enough of it, some of it, little by little, was being reused. And so either Athena was eating it in customer loyalty, the customer was paying a whole heck of a lot, or it wasn't getting done. It was sort of sitting in the queue. And this approach, I think, is what I certainly would have done had I the architectural foresight and the toothpaste memories that I needed.
No, that makes a lot of sense. So, I mean, unified patient records really are different. They really will help manage a network, help you take care of patients, give you comprehensive insights. You can start applying AI. You can start learning as a team about how to better take care of populations and teams. So let's talk about this issue around value creation, really, because I think your point, it was all about the business model. So, Glenn, we think a lot about creating value in a population health, and you spent a lot of your career doing this. Are these the right levers in terms of what needs to think about creating value in terms of cost, utilization, network, contract management, et cetera? Are we missing something here?
Oh, no. I mean, look, the two issues that we have is price per unit and number of units, basically. And we've got to attack both of those. Now, quite frankly, I found it a lot easier to attack inappropriate utilization than I did price per unit, because you've got market-based benches on your most important assets, which are human assets. And if you start cutting below the market-based benches, you start losing the specialists, the subspecialists, what have you. You can't do that. And comparing the cost for those specialists and subspecialists to what you're paying an interventional cardiologist in Portugal, may be interesting academically, but it doesn't help you keep your interventional cardiologists and what have you. So what we focused on really was a look at what was the underlying reason for the cost, And in the areas where we weren't having to bench to market competition, we would try to attack price per unit. But the major issue was overutilization and misutilization. And that's important not just for the risk-based sustainable business models, but it's also important in terms of the outcome for the patient. And so I think those would be, all of these things are important, but those are where you've got to have the enabling data in order to make the right decisions and change how you're giving care.
No, I think that's right. At Innovaccer, we often look at this model where cost and utilization are the big driver initially, and it varies for different people where their pain points are. But your point about specialists and maybe SNF referrals, et cetera. I mean, there's all different ways you need to leverage a common data source to really manage all of these utilization costs. But I think it's more than that, right? There is issues around who's in the network, what kind of contracts are we going to be succeeding, and this is the business model issue. Jonathan, do you want to talk about value creation from a contract management perspective, managing risk, because that's a key piece that you brought up about the future?
Yeah, I always sort of felt like the basic economics, especially when you get into the big health systems, are the same regardless of whether you're in risk really. In that, you need to grow your numerator, which is the number of people who might need your physical plant and expensive people, faster than you grow your denominator, because as technology leans in on medicine, the number of people per thousand who are going to need any one thing you've built will go down. And you'll feel that in a risk contract, but you'll feel that in a fee-for-service world as well eventually, just by virtue of people choosing less invasive surgeries and choosing surgical centers and choosing drugs instead of surgeries. And so in every case, what you're trying to do is scalably increase the ability to deliver reliable, what you might call CRM medicine, customer relationship medicine, in order to make better use of all those buildings and all those capital campaigns over all those years burdened / blessed you with. So the business model, I mean, risk sort of puts it firmly and squarely in your lap. Most people don't really have risk. They don't really have full upside downside risk, certainly not the health systems. If I was a health system, I would never do that, just because it's too hard to foot the bill. But eventually it's sort of the way things are going. And even if your market even if you resist the full flip, you still have the CRM problem. You still have to somehow make there be more people per bed out there in the world that think of you as their hospital, because the use of bed per thousand has been going down and will continue to.
Yep, important point.
David, I agree, and we made the point, and we're still making the point, that understanding costs, regardless of whether you're in a predominantly fee-for-service market or whether you've really made the transition to value-based or shared risk, is the same fundamental problem. And that fundamental problem, to a large extent, means understanding where your costs are created and which costs are actually amenable to better management, essentially. And if you look at what was done at Geisinger and what's been done at about probably a couple of dozen leading organizations, you're aware that I would say 20 to 25% of chronic disease, which is mismanaged now, that ends up becoming an acute care hospitalization, in the near future will go away. So you're going to have to compete, if you're hospital-centric, for more true acute care need. And in most markets, some are going to win and some are going to lose. And the winners are those that will be able to control their costs, even if they're still in a predominantly fee-for-service market. And that's where enabling technology is absolutely critical.
No, it's a great point.
I think that's spot on, because a lot of people think I can sort of slow putt the pop health thing, because I'm pretty sure I can say I'm in an ACO but not really be at risk. I can get a little gain share or something, and I can sort of slow dance this down the road. But if you look at, I'm chairman of the board of Firefly, a whole nother future that still requires you to have the same technical prowess is, Firefly goes and says, look, we'll be your primary care doctor 24/7 within 5 minutes through an app. And so in Massachusetts, where it's starting, thousands of people are saying, yeah, actually, the ability to talk to my doctor in 5 minutes is a lot better than having some office. And then whenever we need anything, we are renting office. So if we need an urgent care, we have a network of urgent cares. When we need a hospital bed, we have a network of hospital beds. And the people who get to be in that network are the people who can understand and participate in a unified patient record, right? So we're this independent entity that's got, responsibility for the whole life. And we are only going to send our hospitalizations and surgeries, et cetera, to people who can essentially write to our Facebook wall. And so and we're, second thing we signed was an Innovaccer deal, so that somebody else could go into the plumbing of all these places to get our integrated sort of Facebook wall-esque medical record together for us. But it's the same challenge. If many, and by the way, Amazon just announced, or didn't announce, but got outed, building a very similar care model out in Seattle initially for its employees, but we hear that they're going to go to market. That's an alternate to risk version of the future, which still looks fee for service, but it's a very, very tech demanding fee for service, where you've got to be able to guarantee a certain bundle of services, be able to stand behind it, and be able to seamlessly integrate with some other record holder. Same ETL problem, not for risk, just for winning bundles of referral.
No, I think that's a great point. I think once we get everything, with ETL into a common framework, a connected care framework using a common data model, you can start to do analytics and start to look at all these complex problems about where your pain points are, how to solve them, track your management of them. And Mercy One of our clients, part of the Common Spirit enterprise, once they moved to they were very successful to begin with, but once they moved to a common data model, a unified patient model, they were able to change their shared savings from 0 to 5 million in just 2 years by starting to really understand from a complete holistic view of the patient record, a unified patient record. So let's take a quick view of, everybody's moving into dabbling in primary care, in value-based care, doing some ACOs, clinically integrated networks, maybe taking on a little bit of upside and downside risk. Let's ask our audience, what's the most significant barrier right now preventing their organization from succeeding in value-based care? Is it lack of coordination at different levels of the enterprise? Is it siloed EHRs and the lack of critical data at the point of care for the physician, care coordinator, or social worker, family member? Is it lack of a referral management effectively to see where they're getting waste and poor outcomes, or an inability to address the social determinants of health or other non-clinical factors? So let's quickly ask the audience, but let's talk to both of you. Glenn, where do you see today the barriers that people are struggling with in achieving really good performance and improving outcome and reducing costs, entering into these value-based care contracts?
Well, we spent most of our time trying to fundamentally change how acute care was delivered once it was in a hospital setting. The next phase was to do prevalent chronic disease re-engineering, and yet now most of what I'm focused on is value emancipation before an individual gets referred in for an inappropriate hospital-based diagnostic or therapeutic. Or the second most important area for value emancipation is once someone has a legitimate intervention, how they and where they get rehabilitation. So the ability to take responsibility, even if you're hospital-centric, for the before and the after is huge. And all of that is predicated, that responsibility being met is predicated upon having a new set of data that's available. to whoever the central risk taker is in that expanded bundle. So I think, and that's even, that's expanded even more if you've got to deal with a Medicaid MCO, because you're having to put in a lot of social determinants responsibility taking, and that's even another silo. So getting all these silos together is really important. Figuring out how to apply the data in a usable form to a whole series of different areas of expertise to change the behavior of how the indications are managed and how the rehabilitation is done is another big challenge.
Excellent point. Let's check into our audience and see what they are struggling with today. If we can bring the poll results up. Boy, this is interesting. I'm surprised by some of this. Jonathan, what's the most significant barrier? And inability to address social determinants doesn't seem to be much of a barrier. This is interesting. What do you make of these results?
I think it's that social determinants are too far away from I agree with that being low. I mean, if you think about it, if you've got a big heart transplant coming in, you can have 12 people be on the phone to everybody and pull together everything that you need by fax and note card, and you can have the fellows and the residents standing around sort of verbally rebriefing each other, and you pretty much get most of everything, right? Now you move out to a colonoscopy. Well, just do maybe we can get the insurance information and some demographics from the referring provider. When you get way out to, somebody who maybe in 5 years will hit the emergency room if they don't start sleeping and eating better, it's like you can't, the cost of acquiring the data to do the nudge is too low, too high for the benefit, which is too low. So of course, coordinating inside the enterprise on a clear and present referral or situation or coordination, is the way you feel the lack of data integrity, the lack of a unified data model first. And, somebody misses their sleep on their Fitbit is the last, but eventually it's all the same thing. All right. So this is how, I would imagine it, right? That which is closer to the central nervous system, hurts more and gets a poll vote, more readily. But honestly, if you can get the cost of ETL down to closer and closer and closer to zero, and the transactional cost goes down, then your ability to deliver care out at the outer edge and keep customer relationship management strong goes up. If the cost is as high as it is to go get 17 faxes on an inbound transplant, you can't do it for anybody but a transplant, right? So it's about moving that cost of acquiring data down to zero, so that you can do more with the data.
Yeah, no, that makes sense. It sounds like people are really still struggling here with lack of coordination within their enterprises and siloed EHRs. Glenn, I think that's the way to read this here. What do you think?
Well, no, I agree. And since horizontal M&As have kind of taken over the last 3 or 4 years, it's probably even more difficult to deal with all the heterogeneity of the amassed mainly hospital centrics and the group of referrers into those hospitals. So I think that's probably why you've got lack of coordination at the top of the list. So I agree. The other thing, quite frankly, is even with value-based care right now, as Jonathan says, SDOH is still out there on the margin, but it's certainly still out there on the margin in terms of your net your net penalty compared to when you screw up on lack of coordination or you somehow can't mitigate the siloed EHRs. It's still you're still getting a huge lever on your net, whether it's fee for service or whether it's value based on your hospital centric I think productivity.
No, that makes sense. And, this is great. We've talked a lot about the benefits of unified patient records. Providers get information from beyond their EHR. Care teams can start, working together and automating tasks using various forms of AI and robotics. And then also healthcare leaders, most importantly, can start managing cost and quality across extensive networks and deal with this complicated multi-system environment and this multi-data environment. So I think I'd like to just sort of, before we get to the audience questions, and for the folks on the 500 people that are still remaining, if you could please enter in your questions into the text box, we'll get to these for a moment. Let's just sort of summarize. We start with Jonathan and just say, you spent a significant portion of your career co-founding Athena Health and trying to tackle this problem. What were some of the lessons you learned coming out of that journey? Jonathan, are you still with us?
Oh, I'm sorry. I thought you were asking the group. What are the lessons I learned coming out of the Athena Health journey?
Yep. I mean, you spent a significant portion of your career looking back.
Don't believe Elliott Capital. No, I think that in all humility, I always felt like the job of the CEO was to make sure that there was still, thousands of miles of unplowed soil for your team to go and get, right, to go and farm. And so constantly refactoring your addressable market so you had more to do. And what I didn't balance it with was some humility about, what I'm already stuck being. And I felt like with the capital and the know-how that I had, I could do that. But I guess I couldn't convince, I had enough nabobs of negativity around me that I couldn't convince people to make that turn. And so this idea of thinking of medicine as an ecosystem rather than a single player story, a play with one character, increasingly is what I'm left with is, look, if Athena does nothing but actually get rid of the revenue cycle and all the scut work associated with it from clinical people's lives, that's a pretty good life story. As long as it can then integrate with people who are going after other aspects of the ecosystem, like creating a unified view of the patient that doesn't cost more than the profit you'd get from the care. And my big learning is that everything is going to happen in clusters, in tribes, and that anybody who tries to do it all will either fail or do it all badly for a while and then fall. And so, hence my search for, the connective tissue that's missing in medicine, and my involvement with these guys.
Yeah, well, thanks. That's a helpful perspective. Glenn, your perspective from your time at Geisinger and XG and to tackle technology?
Well, first of all, it's all about behavior change, and behavior change ain't easy. Whether you're talking about behavior change of providers or behavior change of patients or behavior change of purchasers in the latest context with Health Transformation Alliance, and the sweet spot is to enable the behavior change by making the enabling technology as easy to adopt as possible, as synergistic with how you want to change the actual caregiving process or care getting process. And quite frankly, if Innovaccer had been around when I was running Geisinger, I think I would have just been delighted to ask it to come in and become a partner. Because as Jonathan knows, we started out being monogamous for probably about 12 of my 15 years with Epic. We couldn't have done what we did in terms of moving to value-based care without Epic. But towards the end of my tenure at Geisinger, we became polygamous, and we worked with Athena, we worked with Cerner and what have you. But the issue, particularly with Epic, was we had a template. It was a good template for what it did, and a lot of how we kind of reorganized how we cared for patients had to be pushed into that template, as opposed to starting with an idealized outcome in terms of optimized caregiving. And I think that's the big difference between Innovaccer and a lot of these electronic health records. Not so much Athena, I have to say. Athena was much easier for us to work with. So I think it's all about behavior change. The thing that attracted me to Innovaccer is the ability to actually partner with organizations that are very different, but all have the same intent to improve the value of what they're providing, but to do it in an agnostic fashion, working with a lot of the silos that are already there, not necessarily having to rip them out and replace them, but working with them to the benefit of the people that are getting the care or that are providing the care.
That's very helpful, and I appreciate the comments. I appreciate you both being involved as advisors to Innovaccer. And again, we look at this as a unified patient record, being able to really bring us into the future. So let me kind of give a quick overview of, we see a lot of organizations starting to be successful using this approach, but really want to take these questions from the audience. So first question I see up here is, one of the problems for payers is really trying to get clinical information from the EHR across the market, right? Hospitals are hesitant to give data to health plans, and when they are, it needs to get prioritized. How do you address this complicated issue? And providers and payers generally don't trust each other. So let me start with you, Jonathan.
Well, I think that's right. Trust is a huge barrier in all of this, and we're struggling with this across all information. I mean, the whole blockchain concept, the governance quandary is what most people are stuck on. The fact that these guys, are still making sure that control goes to the person who shares, and only sharing what people want, and people on both sides of a transaction want, while simultaneously getting the efficiencies of sharing feeds. So, the pulling out of the data from Blue Cross of wherever you want, and the mapping it into this unified data model, and then the pushing it into the table spaces of the client. That can all be shared without the business model, without the participants being sort of outed. And then once there's a fair and appropriate and safe and mutually rewarding business reason to share, further, the incremental work at Innovaccer to flip the switch and share more is not zero, but just darn near. And that's why we can include, for example, live benchmarking from around the country without having to do more work. It's cool to have to look at a report and be able to peek over to the right and see what everybody else is doing, even if you've never met them.
Yeah, no, I think it's a great point. And I think part of this sort of unified patient record allows payers and providers to start getting stuff in a common data model and collaborating, which is interesting. Glenn, you've been working with employers lately, and they're the folks that hire these payers generally, even if you think about government being an employer in some ways. So what's the employer perspective here around this whole trust issue?
Well, the fundamental, look, I have it, I'm still, despite my age, extraordinarily positive about things. Otherwise, I wouldn't still be in the game. But I think there are a whole series of experiments that are getting the payer and the provider closer together. And part of developing trust is actually doing things together and achieving success. And success here means a joint positive business model and better outcome for a shared constituent. And the shared constituent would be the patients on the part of the providers, and the members as part of the payers. And what Innovaccer does is it proves the point that the technological issue can be solved and can be solved in a frictionless way. And it doesn't bring in, here's a product where we can create trust, but it creates a frictionless engineering solution to data from the payer side and the provider side that can be aggregated. And then presumably, as you use it together and you show that there's a benefit to the shared constituents and a joint benefit in the business model, trust will develop. So that's number one. As far as the purchases are concerned in HTA, the purchasers are focusing on creating a long-term relationship between them as purchasers, their sponsored lives, i.e. their employees, and the provider. So the interface there in terms of the aggregated data and the Innovaccer sweet spot is being able to create an interface so that the sponsored life is motivated towards the right provider. And the right provider is the value-based provider, basically, because the companies can't mandate where the employees go. The employees have to decide that themselves. And the enabling technology is really, really important. As far as the payer is concerned in the big self-insured companies, you know, the TPA function may become fundamentally different. So that would be my answer to your question, David.
That's great. And I'm looking at another question coming in here from the audience. So, you know, Jonathan, how do you think about automating clinical guidelines? Like, you know, clinical information is so important. We're going to have this unified view. How, like, what's needed at the point of care when a physician is meeting with a patient? You know, they're going to be the quarterback. We want them.
Why are you asking Jonathan that? You should be asking me that. Gee.
I'm a doctor. I've watched so much TV now. I can answer all clinical questions.
Right. Well, I gotta say, Jonathan's actually thought about information at the point of care for a long time, and Glenn,
I love it. I don't deserve the question. I'm taking it anyway. Sorry, Glenn. A little plug for Buoy Health. You know, there's more and more people sort of trying at the edge, you know, maybe do the triage free to anyone. They got like 25 million uniques now a month hitting their little self triage thing. I'm not sure what they do with it after that, but at the low end, you know, high scale free sort of self-help, I think there's some utility for that. I think when you get further down the medical funnel, I feel like we're not there yet. The fact that we don't even have a reliable unified patient record to work off of, like trying to build a fancy bot to answer all your questions rather than just trying to pull together a basic picture of the patient that doesn't leave out the massive emergency room visit when somebody visited New Jersey or whatever. That's just, we're just not, it's a little bit like the comment at the beginning, you know, we're coming full circle. Like, that's cool PowerPoint. Like, sure, a bot that can answer all your questions, excellent. But where we are is we just don't even have the data for the bot to look at yet. And so where we are is just the practical, tactical work of pulling together all these disparate sources of information about patients in a way that's close enough to costless that you use it all the time. And then, of course, we can automate and, you know, walk people through the triage forks and get rid of the scut work that doctors and nurses are doing today. We're just not, that's actually not the most interesting thing to work on until we get past this rather urgent at this point, practical, tactical sort of gaps in the picture of the patient.
Nope, that makes sense. And Glenn, this is what I was going to come back to you as a physician, right? As a fellow physician, you know, we read every day and we talk to our colleagues, it's death by 1,000 clicks and my doctor's not talking to me anymore, he's busy on the computer. How are we going to solve this workforce issue?
Look, as you know, and as we've discussed a number of times, there's a huge amount of care that can be optimized by redirecting who does what for a lot of prevalent acute issues and prevalent chronic disease issues. And you know, a good example of that is how we re-engineer care to optimize treatment for type 2 diabetes. And what that does, and a lot of that can be optimized with enabling technology, quite frankly. And what that should do is free up time for the endocrinologist in one case or the primary care physician in another case to spend quality time, you know, directed at asking different questions and doing different things to the benefit of the patient.
Well, that makes a lot of sense. And I'm glad we ended on that point because it really is about care and being able to provide care and being able to develop that relationship. So I want to just close by thanking the audience for participating, particularly the questions you asked. And I want to thank both of you for being involved with Innovaccer. And I want to thank our clients. You know, I slipped through this slide very quickly before, but you know, we've been tremendously blessed by being able to work with lots of clients. I know both of you have been helpful in this regard. So a lot of organizations are being very successful in value-based care, particularly leveraging these social determinants of health, this new frontier. And again, thank you very much. Thanks to our customers, and thank you for coming to this webinar, for those of you who are participated today and solicited your questions. We'll send out this PowerPoint deck, and we'll send out some research papers for you to take a look at. And again, big round of thanks for everybody for attending. And Jonathan, Glenn, this was great. Appreciate it. Thank you very much.
Thank you,
Thank
David.
you.
You're a classy host.
We got classy customers. Thank you very much.